Okay, so I just want to take a minute to discuss this client's labor and what I'm seeing. So she's G1, P0. She's been in labor for 20 hours. And the last 6 to 8 hours, she has been having contractions every 3 to 4 minutes, and she's feeling quite discouraged. So I just completed a vaginal exam and found that she was 5 centimeters dilated, 90% effaced. There's a bulging bag of water, and she's at the baby's at -2 station with the head poorly applied to the cervix. My differential diagnosis for slow progress at this point in labor includes compound presentation, asynclitism, brow presentation, or other deflexed head positioning, a short or nuchal cord, and also true cephalopelvic disproportion. Now, brow presentation, compound presentation, asynclitism, these things can slow labor, but they are also all manageable. So my management at this point is going to include continuing with good fetal heart tone monitoring every 20 to 30 minutes, as well as through a contraction at least every hour. And we can listen more often if indicated. And then because she is feeling tired and discouraged, I would love for her to have something to eat and drink, as well as get some rest, which at this point in labor essentially means laboring in a lying down position, preferably side lying on the side of the baby's occiput. Once she's had some time to rest, and have something to eat and drink, then I want to go back to being more active in labor, using upright, forward-leaning, asymmetric positions, such as leaning over a counter with one foot up on a stool, or taking the stairs but doing wide steps as you're going up the stairs. We can also incorporate abdominal lifting or abdominal sifting with a scarf. The key is to keep changing positions often so that the pelvis is opened on different planes and in different angles, which allows the baby to just shift her head to enough to get into a more favorable position for birth. Now, at this point, the bag of waters is intact, and we want to encourage the bag of waters to stay intact as long as possible because it provides buoyancy and cushion, which helps with the baby being able to reposition their head. Okay, so fast forward a couple hours, the client just experienced SROM and is having the urge to push. So I do a vaginal exam to confirm that she's ready to push, and I find that she's 10 centimeters dilated. The baby is at 0 station, and I'm also feeling the baby's mouth and lips at 12 o'clock. So in my head, I think, okay, this baby is converted from being in a brow presentation to a face presentation with mentum anterior. And mentum anterior can be born vaginally. And at this point, we can use expectant management as long as there is progress and reassuring fetal heart tones. Some ways that management changes with face presentation is we're going to want to listen to heart tones as continuously as possible from this point on. And we're going to want the client to get up and out of the tub to make this easier to do. It also allows us to better monitor the baby's descent and more effectively apply perineal support during the crowning phase. The client should use any position for pushing that feels good to them, as long as it allows full freedom of movement for the sacrum. Hands and knees is great, squatting is great. We essentially just don't want them like on their back or on their bottom to prevent that sacrum from being able to move to its full capacity. So then as the baby is crowning, then I'm going to apply gentle pressure to the baby's brow to allow the mentum to slip out and under the pubic bone, as well as to slow the birth of the head to minimize tissue trauma. We need to be prepared to suction as indicated, but for this baby, as face presentations often are born face up, and we'll get a face full of fluid. We'll also be prepared to initiate NRP as indicated. In the postpartum period, we will be monitoring for respiratory distress related to laryngeal edema in the baby. We'll also monitor their facial bruising and swelling, and arnica should be considered to help minimize any swelling or bruising that may occur. We'll also revisit the parent's choice regarding vitamin K supplementation due to the new risks that are associated with traumatic birth. And lastly, I will do a very thorough exam of the perineum to assess the need for sutures, as tearing is common with face presentations. That's it.